Good morning and welcome everyone. And we are looking forward to this conversation. Today, our guest is Dr. Kanda. Thank you so much for being here, Dr. Kanda, and welcome.
Thank you. Thank you very much. Thank you for inviting me as well. It's a pleasure to be with you.
You are welcome. Please tell us more about yourself.
Yeah, I'm Dr. Kanda, and I'm working as a medical officer, a medical doctor in community mental health in West Rand district in Gauteng, in South Africa. I am as well a logotherapist, and I facilitate the logotherapy course at the Viktor Frankl Institute of Logotherapy in South Africa, and the UNISA Center for Lifelong Learning. I am also an anthropologist. It's important for me to share these so that it would maybe explain later the reason why I say some of the things I'm going to say. So I'm also an anthropologist, and I'm married to a beautiful and smart wife, and I've got 6 beautiful artistic children.
Yeah. Wow, that sounds very meaningful and
Yes.
wonderful. Yes.
Thank you. Thank you.
How did it come about that you linked the logotherapy and anthropology with being a medical doctor?
Yeah, that's a good question. I happen to be interested in logotherapy through my own challenges in life. I went through tough time in life. I'm originally from DRC, and yes, after my training in medicine and my training in postgraduate in neuropsychiatry, I went through some challenges, and I realized that I needed something more than medicine only. So that's how I came across with logotherapy for my own sake, because I really needed to find a way or a reason to continue living. But in the same time, being passionate about mental health, I also realized that generally mental health in Africa is quite challenged by the socio-cultural context. So why I studied anthropology. But as I was studying anthropology and logotherapy, to my surprise, the two fields merged, and they became connected. So actually, currently, I'm more interested in what I don't know if other people have that. You do have existential anthropology, but for me, I find logotherapy as a meaning-centered existential anthropology, which is very exciting for me because some of my work and research based on that framework of meaning-centered existential anthropology.
That sounds very interesting. You inspire me to go and read more about it and find out more.
Yeah, yes. It is a very exciting, for me, a very exciting field where many disciplines can be put together for the service of the other people. Yeah.
Thank you for sharing that. And could you please tell us more about your view on presence and what links you see between presence and meaning and logotherapy and anthropology and the medical field?
Yeah, and that's actually why I presented myself the way I presented as a human being. I'm married. I'm working. I do have friends, and I have interest. And my interest, as I say, it's in logotherapy, or as meaning-centered existential anthropology. So to share my view of what could be presence, that's your question. I thought of sharing this quote This
Mm-hmm.
is about Frankl. It is said to have said some years back that first, this is Frankl saying, first I wanted to become a doctor, then I opted to become a good doctor, then came the wish to be a good doctor and remain a human being. I'm still trying. End of quote. This is
So
what
true.
Frankl said some years back. And for me, as I was thinking about our conversation about presence for health professionals, this is what came into my mind. That when we meet in our work as health professionals, it's very important for us to realize that we meet as health professionals, but first and foremost as human beings.
Mm.
We should not lose sight of that. That when I meet my clients or my patients, I don't know how one would like to call them, I meet them first and foremost as human beings before them being patients and me being a doctor or a nurse or any other health professionals. So for me, inspired by logotherapy and the work of some existential anthropologists, I would say for me, then presence, it's a mode or a way of being in the world with other beings. So it's a way of being in the world in a context with other beings. And then beings could
Mm.
be any beings, human beings or other beings. Yeah, therefore for me that's how I would describe presence. And if we look at it that way, as I say, it's a way, then it means there are many ways of being present. And there is one existential anthropologist who talks of degrees of presence, basically referring to the varying intensity of presence. Like in this moment between you and me, I can be intensely present as I can be almost absent. Um,
Mm.
I thought this is a very, very important thing to observe, especially in our context in South Africa, where we are talking of children growing up without parents because they are away working. Sometimes parents can be there, like during this COVID period, they might be present, but at a very minimal intensity, almost
Mm.
absent. I don't know if it makes sense. So for me, presence for us health workers, it's an intentional way of being with the other person, and
Mm.
that is an intensity. This existential anthropologist, who is mostly working in a French world, actually uses the term volume of presence. You see, the volume of presence, you can
Mm.
or you can reduce it, and that for me it's very important. Yeah,
Mm.
yeah,
Wow, wonderful. While you are speaking, I just realized the importance again of presence, and that we recognize ourselves in the first place as a human being with other people, and then also the intensity of the presence we have with other people. And I think that brings so much meaning to the interaction with others, with fellow
yeah,
workers, with our
mm,
family, with the patient.
yeah,
And
yeah.
I'm wondering, for yourself practicing this, do
Hmm.
you find it easy to practice to put up the volume high, the intensity high with people around you, or how do you keep it up? What makes it easy? What makes it difficult?
Um, you see, that's why actually I shared that the quote from Frankl, where he says, "I'm still trying."
Mm,
So presence. It's for me. It's a process. It's not an event.
mm,
It's it's an activity we engage intentionally, continuously, because we can
mm.
decide to be absent as well. So
Yes.
yes, it is difficult, and so for me, it's something which is intentionally decided upon and which we decide to engage in. So in
Mm,
each moment we are called to decide. I don't know if it makes
mm.
sense. We are called to
Yes.
decide how much volume do we want to put to the presence. And but I
Mm,
believe for as a health as a health professional, it becomes very important for me. And this is something I've also shared in other spaces that for me, healthcare, it's not only, as some have said, made of the emotion concerned, of being concerned of other people, and made of the technical components, what we know to provide to other people. But I believe care also should include an intentional component that I
mm,
decide to care for a particular person. So, in that way, it's actually me deciding to be present for a particular person. So, it's
mm,
not always easy. The context, as we say in the world, the context can be very challenging for me to be present. And the
mm,
person I'm interacting with as well can be challenging for me to be present. My own internal world through which I'm going, my own anxiety, fear, and excitement can also be a challenge to my intentional presence. So especially in this period of COVID, we are working
mm,
in a very anxiety provoking situation as health professionals. And that anxiety on its own becomes a challenge for me to be present in the moment. So it's very important for me to be aware of that. Yeah, so it is for me an ongoing exercise, an ongoing effort, which I have to intentionally decide. Yes.
Okay, wonderful, great.
Yeah.
How do you think we can help healthcare workers to have this intentionality and make this decision and to continuously decide to be present?
It's a tough question. It's a tough question because it's a question I've shared with my colleague, and it's actually basically how do we improve the quality of healthcare? How do
Mm,
we encourage and teach and facilitate presence in what we are doing daily? So I wouldn't want to pretend to say that I have the final answer, but I believe that it's time for us to change the and to be aware of um, the assumption which supports our profession, our work. One
mm,
of the assumption, or one of the, for me as a doctor, is we are very aware that the biomedical approach, it's very limiting. It actually takes away our presence because we reduce everything at the biological process, at the disease level. And if, as a doctor or as a nurse, I engage with the disease, I actually lose the person. So
mm,
it's very important for us to keep that approach, but put it in a bigger context where we then actually decide to relate with the person. And
mm,
it's actually challenging because we need to believe that the moment we start relating to the person, we start to listen to the other person, we would actually find answers to what is wrong and what could be the problem, the illness. I don't know if it makes sense. It's actually like as if we are deviating for the disease toward the person having the disease, with the faith and the hope that by connecting with this person would happen to understand better his or her condition. I don't know if it makes sense. So for me, that would be the way of encouraging presence in our practice is to become more and more aware of how we relate with other people and how we keep that humanness. How do we keep our shared humanity between us, and to always remind ourselves that first and foremost, I'm dealing with a human being. The illness and the treatment and other stuff follows. But if we put more emphasis of the illness and its biology and all the details, we run the risk of losing the person. And by the way, the moment we lose the person, we generally lose ourselves, because the other person can also feel that is being reduced to his condition, his or her condition, and he might lose interest in whatever we are doing, because he feels or she feels neglected and not taken care of and considered. So for me, it's very important to come back to what a human being is and realize that the human being is made of different aspects or dimension which makes him one, because those dimensions are not separated, but they are they are one. So you have the physical dimension, and this is why in terms of presence, sometimes we say this person could be physically present but not psychologically present. So because these are two different levels of being a human being, as well as there is another dimension, is the spiritual dimension, which is very important in logotherapy. Spiritual, not necessarily as religious. These are two different. So, but spiritual, a human being who has the capacity to exercise the freedom of freedom of will, of choice, who can make choice of on different things or attitude one want to take in a particular moment. So if we consider those we consider those different aspects without disregarding the social cultural context, that helps us to become more closer to what a human being is. And that would bring us closer to having a good degree of presence in our practice.
Thank you for sharing that. That really makes a lot of sense. And
Yeah.
it's very meaningful to hear.
Thank you.
Is there anything else that you would like to share about presence and meaning?
Yeah. You had asked me previously before if I could share some stories. So I have two stories. The one is before I learned logotherapy, and the other one is after.
Okay.
So the first story is while I was working in one of the psychiatric hospital. I happened to observe that there was an elderly man who kept being admitted frequently. Every time he comes in as an aggressive person, as described having psychotic symptoms, he would stay some days and then discharge. A few days down the line, they would bring him back again in the hospital. And we kept treating him, discharging, admitting him. It just became how do we call it? The swinging door, is it? Phenomenon.
Revolving.
Yeah,
Yeah.
the revolving. Yeah. So I got quite frustrated and unhappy with the situation. And this time in the morning, when I arrived and I realized he was readmitted, he looked agitated and unhappy, talking to himself. We had also we knew as well that he had what we call now a neurocognitive disorder. They call it dementia. I decided that no, I really need to sit with him without medication, without anything, in his agitated moment, and ask him, if I could talk to him and listen to him. If he had something he could tell me. So I asked him, please, can you tell me, is there anything you would like to tell us? He looked at me almost close to tears and he said, you won't believe me. I said, no, please, this is what really I think we should start. Let me listen. I might not believe you, but give me a chance. I would like to share. He said, look, I'm afraid because if I tell you, you'd again say that I'm mentally ill. I know I'm mentally ill, but you won't believe what I'm about to tell you. So I said, please, I would like to listen and see what we can do. Then he said, listen, I would like you to know that every time I am admitted, one of my cow is being sold at home. So I'm like, you have cows? He said, yes, I do have. I do have quite a number of cows. And I was afraid that if I tell you, you won't believe me that I've got many cows in this part of the country. And I said, but what happened? Who sells your cow? He said, no, every time I'm discharged, I would find that one of my cow is missing. And if I ask the family, I'll be told we sold the cow because we needed money to pay transport to come and visit you at the hospital.
Mm.
So basically, you should know every time I'm being admitted here, one of my cow is sold. And
Mm.
I'm worried because I've worked so hard for so many years in another country, raising money to have enough cows so that I could leave it as a legacy for my children. So I said, okay, fine. I've heard you. I think that's very, very, very unfair and not a good thing. Personally, as a doctor, I wouldn't want you to be admitted. This is why I ask you.
Mm.
You can't be readmitted most of the time. I did not understand what is happening. So what I'm
Mm.
going to do, what I did, I called in a social worker. I should tell you, I did not believe this. I was close thinking that this guy might be having a grandiose ideas or delusion, thinking that he has a farm. So I called the social worker and said, please, can you please find out about this? Believe me, the social worker came back and confirmed that indeed this man has a number of cows.
Sure.
Unfortunately, every time he is at home, his brothers would come, raise up a conflict, whatever. Then he would get confused, he would get agitated, they would bring him at the hospital. And once he's in the hospital, at home, they
Mm.
would sell the car. So we needed to organize a family meeting and appoint the social worker, find people who could stand by him while at home. And this helped us to prevent any
Mm.
more readmission. That was
Sure.
long before I started my logotherapy. And this was an illustration for me. If when I always think about it, is every time we have a client in our practice, we have to be careful not to limit the person to his
Mm.
behavior of being aggressive, violent, or having psychotic symptoms. We need to realize this is a human being living somewhere with other people. But then the other story is long after I trained in logotherapy. And by then, when I completed my training, I told my course leader, a very smart and inspiring woman, Terea. I told her, look, I think this thing of logotherapy is just good for you and I. I don't think it's good in a um, psychiatric environment, psychiatric hospital where I'm working, where I have severely ill
Mm.
people. And she looked at me and said, I'm challenging you that way you have to go and apply your logotherapy. I'm like, it doesn't make sense. These people have almost lost everything cognitively. How do you
Mm.
apply this? How do you engage in conversation with them? She said, she looked at me and said, that is a challenge. You have to see how do you relate with them. And for me, it was a challenge because in most psychiatric hospital I've worked in psychiatric ward, people are almost reduced to an animal life of
Mm.
living where they are just given medication and food and other stuff, but the presence, as we are saying, is not there. They are not listened to. So in a very busy clinic, a family brought me a woman in her 80s because she was very agitated, very agitated. At times she would undress herself and just behave in the most bizarre way. And then I'd already learned logotherapy, and she came. The temptation was start medication, sedate the patient, admit, and so on. I brought the client in the consulting room, invited her to sit despite the agitation, and looked at her and said, can we talk? I would like to listen. Then she looks at me and not knowing what to tell me. And considering her age and the children and grandchildren who brought her, I don't know. In that moment, I look at her and say, listen, are you scared of dying? She said, no, I'm not scared of dying. I would like to die anytime. Then I asked, but what is your wish in this moment? She said, listen, the only wish I have before I die is to see my children reconciled among themselves and live in peace. Because currently they are fighting against each other. And this makes me so worried about me dying, that after my death, my children would continue even worse to become more divided and fighting against each other. So my main wish is that if my children could reconcile and talk to peacefully, relate peacefully among themselves. So when I look at the children, some were like looking somewhere, avoiding. Others looked and say, yes, what she says is true. We have a serious conflict in our family. The moment we start engaging in that conversation, believe me, this elderly lady became calm,
Wow.
and you could see that she was cooperating. We could talk to her. There was no need to give her any medication because I believe in that moment she had realized I am being listened to.
Mm.
So because she was said to have poor sleep and so on, with my medical orientation or my medical profession, I was quite worried about her sleep. Then we agreed with her. Incidentally, she told me that she is a nurse by profession, and of
Oh.
course, she also had a neurocognitive impairment, which she was aware of. She was aware that she had a very poor memory of recent events. She was battling to remember recent and immediate events, but she had a very clear recollection of her past event, childhood event, which she felt she would definitely would like to share with her grandchildren before she died. So we came up with a plan that, look, I would prescribe you a very mild, small dose of antipsychotic for you to sleep and possibly stop what we thought she was having hallucinations at the time. She agreed. Few days down the line, she came in, this time brought by her grandchildren happily. She had stopped
Wow.
medication. She was sleeping without medication. And indeed, she spent time talking with her children about childhood during apartheid time, which she felt was important for
Mm.
them to know what kind of life she went through. And meanwhile, the children also engage into a conversation among themselves. So these two stories, I choose them intentionally because these are the kind of client where we are more tempted to not be present because we say,
Mm.
okay, they are cognitively impaired, they are psychotic, so there isn't much we can do, and the only thing is you give them some sedative and move on with other clients. But I thought these two stories shows clearly that presence becomes important even in that kind of situation. And if you don't mind, I would like to share another quote from Frankl. Um, um, Frankl said, "An incurably psychiatric individual may lose his usefulness, but yet retain the dignity of a human being." This is my psychiatric credo. So for me, this is what I've kept as well as my medical credo in my medical practice is that regardless of how hopeless the situation might be, the other person in front of me is still a human being with dignity.
Mm.
And so he deserves to be listened. So these two stories I've shared and the quote of Frankl I've shared, if we have to come back to presence, for me it's an illustration that the challenge we have as health professionals is to listen
Mm.
first. To listen first to our client because we have a tendency to give instruction, to make an assessment and say what to do and what not to do. But I believe it's important that for me it's first of all, first and foremost important to listen first to the person and then respond. And I believe
Mm.
in doing so, I believe then what some people have observed with HIV and now with COVID is that we need to bring the diagnostic process or the assessment process together with the treatment. They shouldn't be separate. We shouldn't
Mm.
be doing, okay, now I'm assessing, I'm evaluating, I'm doing investigation, then I'm starting to treat. For me, it doesn't work that way. We have to have what I call therapeutic assessment. It means from the first moment I'm in contact with my client that I have to behave, I have to have a presence, which is therapeutic for the client.
Mm.
And for me, I think that's very very important. Yeah,
Mm.
yeah,
Thank you so much for sharing that. That's very, very powerful. And I think your
mm,
message can change practice if we start listening to the person in front of us and seeing them as a human being,
yeah,
acknowledging their dignity. Thank you
yeah.
so much for that.
Thanks a lot. Thanks a lot.
Mm. You spoke about a website that you have and also the Viktor Frankl Institute's website. Please tell us more about that.
Yeah, so in South Africa, we have the Viktor Frankl Institute, the Logotherapy Institute in South Africa, where we basically currently we offer training in logotherapy, and I have my own website as well, which is just at its beginning. It's called Africa Circle of Healing, where we discuss um, this kind of this kind of issues because exactly for me. I feel it's important that we take the challenge of COVID, the challenge of all the pandemic, HIV and AIDS we are going through the chronic how to call them chronic lifestyle conditions, we need to try and humanize the healthcare we are providing. So in this way on these websites, I believe would keep some conversation addressing these issues. Yeah.
Thank you.
Um,
I will.
yeah.
Sorry. I will share the links to the websites in the description to the video.
Yeah.
So thank you for that.
Thank you. Thank you. Thank you a lot.
Thank you. Dr. Kanda, I sincerely hope that your message will spread like wildfire in the healthcare profession. And I would like to encourage you to keep on speaking to us about that and spreading the message. Thank you so much for that.
Thanks a lot, and thanks for your invitation, and thanks for. I'm grateful, and I'd like to also salute your great work you are doing, because I've heard about you. I've worked with one of the one of your students, my colleague, a nurse who put me in contact with you, Lillian. Yeah,
Yes.
I hope that your work with presence for nursing, it's so important and very much needed. So thanks for that.
Thank you very much. Hope you
Okay.
have a great day.
Thank you.